There are a few factors that we take into consideration when we're trying to treat a patient in the first line with metastatic disease. And the most important question that we want to answer for a patient with ER-positive disease is that, when would you consider chemotherapy in the first line setting? So the rule of thumb, if you will, for an ER-positive metastatic patient would be that you would always want to give them an endocrine therapy unless there is a visceral crisis. And with visceral crisis, I'm not talking about just presence of visceral metastases. I'm referring to a patient with a significant disease burden, somebody who's presenting with a lot of symptoms, with lab abnormalities that make you feel like she would benefit with chemotherapy and not endocrine therapy. But otherwise, for every other woman who's not in visceral crisis, your first line choice is always going to be endocrine therapy. So that's the first factor that we keep in mind. Outside of that, you want to make sure that they are truly ER positive from their metastatic site and not HER2 positive or triple negative, because that would perhaps change the way you treat this patient. You want to keep in mind their menopausal status, because for a premenopausal woman, you're thinking about adding ovarian suppression to endocrine therapy. You want to think about whether they have been treated for their breast cancer or are they presenting with de novo metastatic, as in this case with this woman who presented as such with de novo metastatic disease. Because those factors will drive your choice of therapy for a given woman. Given that we now have at least 4 randomized phase 3 trials, one dedicated to premenopausal women with the Mona Lisa 7 trial, and 3 others such as the Paloma 2, the Mona Lisa 2, and the Monarch 3 trials that showed that CDK4/6 inhibitors are effective when combined with endocrine therapy. And all these trials showed roughly a hazard ratio of about 0.5 with a statistically significant improvement in progression-free survival compared to endocrine therapy alone. My practice certainly has been to utilize the combination of a CDK4/6 inhibitor with endocrine therapy for first-line treatment or even second-line if they've not received a CDK4/6 inhibitor in patients with ER-positive metastatic disease. Okay. So I would absolutely consider that treatment for this given woman as well. The data that we have from these phase 3 trials, we tried to identify if there was a particular subgroup that might benefit more or might not benefit from this combination. In other words, because combination therapies are more effective but come in with their own toxicity, the idea was to try and identify a group that might be definitely benefiting from this a lot more than the other group, or a group that might not be benefiting. But what we saw, that regardless of sensitivity to prior endocrine therapy, disease-free interval from their prior treatment, choice of hormonal therapy, premenopausal status, presence of visceral disease or bone-only disease, there was certainly a benefit across all patient characteristics and all subgroups to justify the use of a CDK4/6 inhibitor with endocrine therapy. So I have definitely been using this combination therapy in the first line and second line setting for my patients.